Hello and welcome to Breast Cancer Now's Facebook Live. Tonight we're going to be talking about breast screening. My name's Addie, I'm one of the nurses for the charity, and I'm delighted to say that Noelle Clerkin is here to help me with this. Noelle is a breast service manager, a radiography advanced practitioner, and also a PhD candidate in Belfast Breast Services in Northern Ireland. I'm not quite sure how she gets the time to do all that, but so I will be introducing Noelle to you in a moment to talk about the breast screening program. But just first of all, just to remind you, if you want to post any comments or questions during the session, please do so and put them in the chat box. We'll try and endeavour to answer as many as we can during the session. Otherwise, as soon as we can after the session, probably tomorrow, we will be answering those questions for you. So don't worry that we'll not miss them out. So without further ado, Noelle, it's lovely to see you, and thank you for coming. I'd just like to ask you about why the NHS breast screening program was set up and what it is.
Hello, Addie. Thank you so much for having me. It's great to be here. Such an important question. What is breast screening? So the breast screening service, the NHS breast screening service, which we abbreviate very frequently to NHS BSP, the inception was in 1988 to offer clients from 50 to 70 mammograms every 3 years. And that was to identify, and to ensure prevention. We all know prevention is the best cure, but to ensure early detection of breast cancer. So it has been extremely successful, and the numbers for breast screening have really have been ever rising since then, along with imaging modalities developing and professional roles developing as well, right through to 2024. It's a very exciting time to be involved with breast imaging, but specifically with breast screening. The future with all of this new information is developing, and the future is looking very bright.
Yes, absolutely, and of course, we're talking about a mammogram, aren't we? A breast X-ray.
Yes.
So every 3 years, between the age of 50 and 70, as you say, and we get quite a few questions about why women don't have their first mammogram until possibly. It can be any time, can't it, between the ages of 49 and 53? What's the reason for that?
That's how historically the service has always ran. Statistically, breast screening is more prevalent between the ages of 50 and 70, and that is why screening is offered. So in order to ensure clients are included in the cohort of invitations, it's that time frame that allows us to make sure every client between that age is invited. Now, it's a challenge for this program, but it works very well. We work with the GPs very closely to ensure if you are registered as female with your local GP, that you are automatically sent an invitation. There are trials that have been undertaken in the UK, specifically looking at extending that age range from 47 to 73. And the data from that is still under scrutiny at the moment. But yes, Addie, it is, we all know that breast cancer can develop outside of that age range.
Mm-hmm.
And there is the question of, okay, so why am I not having a mammogram at 43, and or 35 or even younger? And I think I know that the answer to that is that mammograms aren't a diagnostic until the ages of 35. We would not the symptomatic service routinely wouldn't do a mammogram even symptomatically because of the breast density. Breast density as I'm sure a lot of the people watching tonight will understand, that breast density does hide information on a
Mm.
mammogram. And because we are exposing such sensitive tissue, we don't want to be overexposing breast tissue. So I suppose the considerations are there of when you should have a mammogram taken and what's most appropriate.
Yeah, no,
Mm.
absolutely. Um, and of course, you know, breast awareness is all about knowing what your normal is.
Yes.
So in between screening mammograms, and for those who aren't within the screening age group, it's really important that everybody, men and women, men do get breast cancer too, um, check themselves regularly, get to know what's normal for them, so that if they find anything new or different, they can report it to the GP. Even if you've just recently had a mammogram, they don't actually stop you getting any breast problems or breast cancer, do they, Noel? And it's really important that we highlight that it's really important to be breast aware in between screening mammograms, and for women, all women and men that aren't
Oh,
women that aren't within that age range of being screened.
completely, Addie, completely. And as radiographers, that's something we like to emphasize after their mammogram. The mammogram, you're going to get this result now, but make sure that's the mammogram on that particular day. It's very
Mm-hmm.
important from the time you have one mammogram to your next that you stay breast aware,
Yeah,
because the picture only tells a story from that moment. Yeah.
yeah.
Mm.
And the other thing is, of course, the whole point of having a breast screening is that they want to pick up very early problems and very early breast cancers. But of course, a proportion of women will be recalled, won't they, for assessment
Yes.
to the clinic, which can cause a lot of anxiety. How does that work? And how many approximately will be found to have a breast cancer when they go along? What happens when they go along for assessment?
Yes, and you've embodied that so well, Addie. The moment the mammogram is taken, there's three options. I always say, you've got your first option, which we call routine recall, where the client is, you sent a healthy result letter that says all is well, we'll see you in another 3 years. The second result letter you can receive is a technical recall, and this can cause anxiety too. It's
Yeah, of
horrible
course.
being recalled for
Yeah,
something that you don't know, especially when you're asymptomatic. These
yeah,
are well women coming, they're not coming with a symptom normally. So it's, yeah, very important to appreciate that. But that technical recall, meaning that the image needs to be repeated for whatever reason, whether or not the reader was happy or the technical attributes weren't achieved by the radiographer, and that needs just maybe another attempt. So that's number two. And then the third option is a recall to assessment, which is what you mentioned there, Addie. And
yeah,
that's when a lady or a person is sent an appointment to be recalled for further investigation. Now, you're asking numbers there. The numbers can vary so much. It's very, very, we read in batches. So when a batch of mammograms is taken, say, for example, if you take 50 in a session, that's usually the number of mammograms in a session for a reader. Um, on average, you could maybe recall maybe 3 to 5 of those, and five being a high number there. And a majority of those would be, again, nothing to worry about, that we just need to recall these clients just to reassure us that there isn't a change and that is just a normal variant for that particular person. However, we are and with the introduction of digital mammography,
yes,
the images are so sensitive now.
yeah,
We're really picking up minute detail, which is what we want. We
yeah,
really want to be very precise in our image interpretation. However, that's making us recall more that maybe,
yeah.
and the consideration for overdiagnosis is there. So, yeah, there's a factor to be thought of too.
What do you mean by overdiagnosis? Because we do hear that as well, and you read about it as well, about
Yes.
overdiagnosis. What does it mean?
Well, to me, Addie, overdiagnosis is similar to overtreating. We're talking
Mhm.
about overcalling a mammogram in this instance, whereby the reader sees something and calls it back because they know it's different. However, that client would have to go through more testing.
Yeah,
That testing could involve additional mammograms, an ultrasound, clinical examination, plus or minus intervention. And it's this intervention that can raise even further over diagnosis and over treating. If you
yes,
test for something and you're not too sure about it, it can possibly lead to a repeat intervention and possible surgery for something that may not necessarily cause that client problems in the future.
yeah,
So it is a consideration, and it is one of the challenges of screening, and that's
mhm.
the nature of the beast, isn't it? Yes.
Yes, absolutely. And we also hear from many women who are over the age of 70, who, of course, aren't automatically called, for screening. So, and feel quite, they can be quite aggrieved about it because, fair enough, they won't be called automatically, although they can request a mammogram every 3 years, can't
Yes.
they? No.
Yes. Yeah, they can,
Yeah.
Addie, completely. And this is something in my management role, I see very often. And clients with when our team deliver breast awareness events, it's a really popular question. I didn't realize I was able to ring up and make an
No,
appointment,
that's yeah,
And
yeah.
it's not, I think what I emphasize is that your breast cancer risk does not just stop at 70. It's
No.
not a fine line. The trajectory actually increases as we get older.
Yes,
It's just
yes.
not as aggressive. And I think that's something that we don't really consider, and something that units do. And I think there's a balance here too. It's all about the balance, isn't it, Addie?
Yeah, yeah.
That there's not necessarily any more funding for services to deliver additional screening over the ages of 70, but we do encourage clients, especially in Belfast, to attend if they wish and to make that appointment and make a note in their diary of when last they had their mammogram, so they can ring us up and book an appointment and know that they are entitled to that. And something that they often say is, "Oh, is it free? Do I have to pay?"
Yeah.
And yes, it is free, and it's included in the NHS. So definitely, if anyone's listening tonight, make sure
Yeah.
we're a friendly bunch in the breast screening office. Give us a wee ring. Yeah,
Yeah. No, absolutely. Yes. Wherever you are in the UK,
of
hopefully you'll get
course, of
a
course,
warm reception and,
of course.
to allay those fears. But so coming on to barriers as to why people, women won't come forward for screening, there are quite a few really, aren't there? And we've already mentioned a couple of things, but what are the barriers for, you know, not coming to screening?
Yes, yeah, and there are a few, Addie, as you say. In February 23, there was actually, the data was quite shocking. Our uptake rate was sitting at 62% nationally for breast screening,
Yeah,
which is the lowest on record.
yeah,
And yeah, there has been work done to look at why this is so low, and just to explain that the national target is 70%. Of course, we want to achieve over that, but 62% is very low nationally. So barriers that impact breast screening uptake, as you say, there are many. I think the first one that we need to discuss really is accessibility. And
yeah.
accessibility comes in a lot of different formats, doesn't it? You
Yes.
have the physical accessibility to attending a breast
Yeah.
screening unit.
Hmm.
And that can be clients that attend with physical disabilities, and of course, psychological issues as well that we need to take and consider, but also the location and the locality of where breast screening is held, and
Hmm.
how clients can access the breast screening and offer. So I think accessibility is a very big barrier for breast screening. We also have informational, so ensuring that clients are as informed as possible of what is an offer and where screening is taking place, how often or how frequently, and what is the purpose of screening, you know?
Yes. Yeah.
So ensuring that clients are informed as possible, no matter what cultural background they're from or wherever, whatever community they're coming from, you know.
Yeah.
And we can talk about communities from the LGBTQAI community to, learning disability communities and different backgrounds, you know, making sure that we reach out to these teams and making sure that they're as informed as possible. And that's a very, very important priority the breast screening service needs to focus on. And
Yeah.
something I know that my own trust try our best with the resources we have to
Yes.
ensure that we use all healthcare professionals that we work with, from our breast care nurses to our radiographers. Our own PIC team is led by a fantastic assistant practitioner who's so proactive and engaging, and that really helps bring down those barriers and ensure, that we attempt to encourage and not just only ensure, you know, that first appointment, but try and optimize reattendance as well. You know, we don't want it to be a scary experience. We want these clients to come back and see us.
No, absolutely right. And you were talking about the sort of cultural barriers, which of course in some communities it's not, you can't even say the word breast, can you? And it's
No.
a very much a taboo subject. And I think we've also breast cancer now, and a lot of the trusts, a lot of the screening units around the UK are doing the same thing. A lot
Yes.
of EDI work to, you know, to include, make it as inclusive as possible. And they're doing a lot of promotional work, trying to get those hard to reach communities to actually attend and not be frightened. I think, as you said, you know, it's so important, isn't it? And, you know, and of course, one of the barriers, I think, is still there's still a backlog, isn't there, from post COVID when
There is,
obviously, you know, the
definitely.
breast screening program had to be halted for obviously very important reasons for about 4 or 5 months, wasn't it? And I mean, since restarting, it's we're still not quite catching up with. Why do you think that is actually, Noel?
I think it's in a multitude of reasons, really,
Mm.
Addie. You know, it had a huge impact on the whole, on everybody. You know, the whole
Yeah,
world was affected by this, and I think there's huge projects that really try to uh, really try to increase the uptake and ensure that these, additional clinics were put on to make sure that we try to claim back some of those numbers.
yeah,
But I think we only see the impact really because of the round length of screening, in
yeah,
that we can see in 3 years after COVID has happened. And I don't think we'll see the full impact of this for another few years, and
yeah,
to see exactly what cancers have been missed because of that important time frame that we lost.
yeah,
And even though a lot of units have clambered back and clients have been screened, even, you know, the consideration that they may have been late, you know, those few months may have really impacted prognosis for a lot of
yeah,
clients attending.
absolutely.
So
Yeah.
it will be interesting to see in the next few years. And I know a lot of research is undergoing at the moment to know the impact of COVID
Yes.
and how, yeah, and I suppose we wait to hear that.
Yeah.
Yes.
Yeah. No, that's it's really important information, isn't it? Because you know, we've sort of almost people have forgotten about it, but actually, it's having an ongoing, you know, impact, isn't it? So, um,
Yes.
we've had a few questions actually, and I think we've probably answered a couple of them. One's a comment actually, but Jane asks, why do they stop doing mammograms at 64? Well, it's actually 70 now, isn't it? And I think we probably did answer that in that the you know it is about financial you know, the financial impact on a screening program, but also that the, you know, as you get older, the breast cancers tend to be slower growing. and a lot of them will not impact on your lifetime, in your lifetime. So I think, and somebody else, Glynis has said, I've done a self-referral for mammogram. I'm 74. A lump was found. It was a grade 3 and aggressive, so that's the highest grade breast cancer. In too deep to feel it. So was glad that she went for screening, which is, thank goodness, and good luck, Glynis. I hope that goes well
Yes,
for
well done,
you.
Glynis, for going.
Yeah,
Yeah, very good.
yeah. Um, let me. We've also had. Oh, this is an interesting one. I don't know if you can answer this one. Rochelle asks, I've just had a recurrence in the side where she had a breast reconstruction. So it sounds like she had a mastectomy, so the breast removed, and then she had a breast reconstruction. Why do we not screen reconstructed breasts? Which is a fair question.
Yeah, definitely, Addie. A very fair question. Um, and for screening protocol, no, we don't image the reconstructed side because, in theory, the breast tissue has been removed through mastectomy surgery. However, and yeah, this is really important, is that it's impossible to remove every cell of
Yeah,
breast tissue within, so it's so important for that, client or person to make sure that they're staying breast aware, and that to know that they can still be seen symptomatically, where the protocols can vary, depending on the radiology and surgery team. Mammograms can be performed, so to speak, on the reconstructed
hmm,
side, but just a limited view. But
right.
from an image interpretation perspective, from a reconstructed breast on a mastectomy, you should just be seeing skin, muscle, as fat, and an implant if there is an implant in
Yeah,
situ,
yeah,
and or muscle if it was a DEP reconstruction dependent. But it's whether or not that mammogram is valuable and diagnostic. So from the screening perspective, no, we don't screen on the affected side, or the reconstructed side, but we do emphasize the importance of being breast aware on that side, and not just on the breast, but under the arm,
yeah,
on the collarbone.
yeah.
Your breast tissue can yeah, live outside of the breast, yeah, sometimes as well.
Yeah, no, thank you. Yeah, it is really important to be breast aware, and which can be quite difficult. We hear that a lot as well, don't we? That it's quite difficult to check yourself when you've had surgery, especially if it's quite recent. But it's, if you're in any doubt at all, or you're not sure, then it's really
Definitely,
important to report those changes, isn't it, to your treatment team or GP. So
completely.
yeah, um, so when we talk about the breast screening program, we're talking about women between the ages of 50 and 70, but actually there are quite a lot of sort of research going on as well about stratified, personalized screening for high risk. And when they talk about high risk, what do they mean by that?
Yes, and yeah, definitely, Addie, all of these terminologies that can confuse us, even stratified, I find,
Yeah,
yeah, what does this mean? What do they mean by these terms? So obviously, stratified, we're talking here about stratifying the screening process according to risk. And when we talk about high risk, it's clients or people that attend for screening that are at a higher risk of developing breast cancer.
mhm,
And the stratified breast screening approach is to increase the amount of mammograms that a client has, and yeah, that is sitting at a higher risk of developing a breast cancer, in comparison to reducing the amount of mammograms a client has who is at a lower risk of breast cancer, of developing breast cancer. So with regards what is high risk, clients can be at high risk from a number of reasons.
Mm-hmm.
The most common one is being a woman. Funny enough, being a woman is the biggest risk of getting breast
Yeah.
cancer. But second of all, you know, family history of developing breast cancer. If you have a family history, it's really important to make sure you inform your GP of this, and to make sure that you're within the program at the currently, that you're availing of any screening that is available for you. Those also who have a genetic mutation.
Mm-hmm.
And this is something that we're still learning so much about, you know, and we're only, I think, on the forefront of it. You know, we're learning so much about the different genetic mutations that can put us at higher risk of breast cancer, of developing a breast cancer. But also, we can talk about, even if you've been through radiotherapy, specifically mantle radiotherapy to the chest,
Mm-hmm.
these put you at a higher risk of developing breast cancer. And I think it's really good to get in touch with your breast screening service, or indeed your GP, who can navigate what options are there for you.
Yeah.
But looking to the future and personalised medicine, you know, we need to consider the advances in imaging technology on with regards breast density. We know that information and data is out there to say that because of increased density leaves you at increased risk of developing breast cancer.
Mm-hmm.
But this yet hasn't been stratified as per se by the NHS BSP, and there's more work to be done on that,
Yes.
especially with the advances in imaging technology and AI, etc. You know, there's a lot of work to do. There's a lot of work to do.
Yes, there certainly is, and but it's very exciting because,
Mm,
I think it's going to change things, isn't it, in the future?
definitely, definitely.
Um, and so lovely. And I have another question um, from actually it's a comment. It's a comment. Michelle says, I've just received a diagnosis of stage 1 breast cancer. I'm grateful that the screening process detected my cancer early on. My surgery is in 2 weeks, so good luck, Michelle, with that.
Look,
And
Michelle. Yeah.
yeah, that's the beauty of the screening process, isn't it? That's the
Yes.
upside of it. That's what I mean. Even though, of course, having a diagnosis of breast cancer is not, that's horrible for every woman and man. But I think the screening process to pick those cancers up early is obviously really important. So no, that's so going back to the family history and the stratified personalized screening. We have breast cancer now have quite a lot of information about family history. If you're concerned about your family history, yes, do make an appointment with your GP or your treatment team if you're being seen, as Noel said, and they can direct you in the right place. So either a family history clinic where you'll be assessed, you'll be sent a questionnaire, and you'll be assessed for your risk of developing breast cancer, and they can tell you whether you are at high risk or moderate risk. What would happen if, in that case, what sort of screening would they receive, Noel, if they were moderate to high risk and they weren't old enough to be part of the screening program?
So, very good question, Addie. And I think trusts nationally deal with it dependent on, it's very dependent and can vary.
Yeah.
With regards, if you're sitting at high risk, you can be referred, you usually, to a specialist, who will map out your risk specifically and then identify where you sit. And this can vary from annual mammograms,
Hmm.
even from the age of 40 onwards, annual mammograms, to annual MRIs or alternate MRIs. And this all helps with informing us and, monitoring the breast tissue in that time frame up until you're due for your national screening at the age of 47 to 50,
Yeah.
usually.
Okay. Thank you. Um, and we have. Let me see. I think we've got a few more questions. What I didn't say actually was that we did touch on the LGBTQI plus community, and we have some. Again, we've got quite a bit of information now on our web pages about if you're um, if you're going through a trans transgender, and if you are registered with your GP as female, you will automatically be invited for breast screening. If you're a trans man, which assigned female at birth, you will automatically be, and you can attend if you still have breast tissue. You'd be encouraged to do that. If you're a trans woman, so assigned a male at birth, and on hormone therapy long term, you can request breast screening via your GP now. So, and if you have any concerns or questions, do speak to your GP or your gender clinic. And we do have, as I say, we do have quite a bit of information. Or you can call our helpline. Anybody with any questions can call our helpline when it's open 9 till 4, Monday to Friday, or Saturdays 9 till 1, or leave a message and we will call you back as soon as we're open. But yes, so if you've got any burning questions after this, and you're not sure, or you want to ask anything else in sort of in confidence, then don't hesitate to give us a call or email us, nurse@breastcancernow.org. I think that's all the questions for now. I think we've probably covered quite a bit about the screening program. Well, Linda asks, how often are you meant to have a mammogram? I don't know if she maybe missed the first part of the presentation, but yeah. So how often are women invited for screening?
Yeah, well, within the UK, it's within 3 year time frame, so we're called every 3 years. But it's an interesting question, Addie. In Ireland, in the Republic of Ireland, clients are screened every 2 years. In America, it's every year, and it's very varied, And there's research to suggest either side, However, this is what the NHS provide at the moment, and it has been very successful.
Yeah, no, thank you. It has. So I think that's all the questions for now. Thank you so much for that really enlightening talk, and it's always lovely to have you work with you, Noel. And so if like I said, if you've got any other questions or you think of anything, please don't hesitate to give us a call. And we also have a lot of health information around the breast screening program, about who's eligible for attending, etc. So please do, also have a look on our website, breastcancernow.org. So, but for now, thank you very much, Noel, and I hope your throat gets better
I
soon.
know,
You
very
managed.
hoarse. Oh, yeah. Thanks, Addie. Thank you.
Oh, thank you. Good night, everyone. Thanks for listening.